Controversies in Urologic Oncology 2023 addresses really frontier issues and really complex controversies or areas where there's challenges in the clinical care and understanding the disease. We really brought, the brightest, youngest, and most dynamic researchers and experts in the field to Vienna to address those issues. We address issues that are very important in non-muscle invasive bladder cancer, muscle invasive bladder cancer, prostate cancer across all the disease states, kidney cancer, but as well other cancers, testicular cancer, penile cancer, adrenal cancer. I think also very important at this meeting, we don't want to only focus on drug therapy, complex metastatic disease, but also prevention, early detection, and management of side effects, adverse events, and how to deliver really the ideal therapy for each patient. That means the concept of delivering the right therapy for the right tumor in the right patient at the right time. And that is what this meeting is focused on, really moving the needle forward beyond guidelines into the future. And we're very happy to have this meeting really in partnership with multiple top partners, that's the Berufsverband der Urologen, the Doctors' Chamber in Austria, as well as the Austrian Association of Urology.
So my presentation was dedicated to en bloc resection for non-muscle invasive bladder cancer. This technique is becoming more and more widespread all over the world due to several reasons. First, we have better pathology. Second, we have less complications. And during this meeting, we also discuss oncological outcomes. And it's important to highlight that in Vienna Medical University, there is one of the largest clinical trial on this topic. And in the nearest future, we will present the data on this topic, and all the professional community is looking forward to seeing this data.
It's a very good meeting, and the input is more, let's say, scientific. Of course, I would try to keep it scientific, but actually the main messages are more surgical aspects and pros and cons. It will be about urinary diversions. We are using different urinary diversions. The main urinary diversions which we are using is the neobladder and the ileum condyle, and I want to stress that there are different diversions also, which might be important in some other people with special conditions after radiation, for example, patients who do not have a urethra anymore, patients with incontinence. And so I want to stress that there is a variety of urinary diversions which we should not forget about.
I'm talking about patient-reported outcomes, a topic we touched a little bit during the day, but I will present some other insights and deepen the topic a little bit. So the patient perspective on treatments, because we need to reflect what we do, what our therapies do with the patients, and this is a very important aspect. This meeting is great. I mean, see all the speakers, the lectures are highly excellent, and also the environment here in the Josephinum is extraordinary, so I'm really happy to be here and grateful for the invitation.
Today I talked about the microRNA MIR371 as a novel biomarker in testicular cancer patients. The potential of this biomarker is to reshape the future, how we diagnose and how we manage our patients with testicular cancer. So this meeting is unique because there are so many people from different nations and urologists, oncologists, pathologists, so it's very diverse and the discussion is fruitful, networking is possible, so it's a great meeting.
So my first talk will be about the triplet treatment in metastatic kidney cancer. We have recently seen the data from a study that investigated a combination of cabozantinib, nivolumab and ipilimumab versus nivolumab, ipilimumab. The study showed an advantage of a progression-free survival versus the doublet, and we are now trying to see where we could incorporate these findings into our current treatment strategies. This is what I'm going to address in my first talk. In my second talk, I'm going to talk about treatment beyond progression. So in medical oncology, we usually have guidelines telling us what to do in first line, in second line, maybe in third line, But actually, if a patient progresses in third line, there is no more treatment left, at least not based on evidence. And the question that I'm going to answer in my talk is whether we can actually offer treatment beyond third line or beyond the guidelines, or if there are no more evidence-based medicine left. This meeting is very special since it involves people from around the world who are coming from areas where the treatment strategies are very different, and I think it's very important that we talk to each other to see how we incorporate our knowledge, all of us, our knowledge into the current treatment design.
My topic will be the implications of detection of biomarkers in circulating tumor DNA in patients with metastatic castration-resistant prostate cancer. So I will want to convince the audience that this is a new biomarker which is able to detect actionable mutations or genetic alterations which might have an implication for treatment of these patients, or for monitoring or understanding the biology or resistance mechanisms of these tumors and the tumor evolution. So how it changed by our treatment and by the biology driven which drives the tumor. So I hope it will get clear that it's a very valuable tool, but it needs an expert laboratory and it needs standardization around the world, that it will be accessible for everyone. It's a mixture of urologists around the world which meet here. I think it's interdisciplinary topics which are discussed here. As we heard the HPV talk earlier, which is very interesting for me as well as a medical oncologist, to hear more about that, and about operation techniques I'm normally not familiar with. And on the other hand, medical oncologists can contribute new information concerning medical treatment. So I think it's a fantastic meeting.
I will be a part of the kidney cancer topic, and as a urologist, in between of the oncologist, I will talk mostly about the surgery. And surgery in kidney is nothing spectacular, but there is a small entity. This is a cytoreductive nephrectomy. That means nephrectomy in a patient with metastasis. There are some controversies. We changed that already a few times. We still don't know what and how to do it. And I'm really, really happy to be a part of it, exactly with that topic, to discuss it with my colleagues, and maybe to try to understand which door should we open in the future to be sure that personalized medicine at that topic will be really used. This is one very social meeting with great program, always great program, very international. People can connect, you see old friends. It is always, every year brings something new. This year we are in Josephinum. It is a great location for such a congress, especially maybe for people that are not from Vienna, who are not from Vienna. And this is always, for me, a fixed appointment where I said, okay, I know the program will be good, we will have some fun, and I will meet my friends. That is special in this format of the Congress.
So I'm talking about the triple therapy in hormone-sensitive prostate cancer, which is a new player since 1 year. Former we had only the ADT monotherapy, then the doublet therapy consisting basically of ADT and new hormonal therapy or chemotherapy was the new standard, and since more than 1 year we have now the triple therapy consisting basically of ADT, new hormonal therapy and chemotherapy, but in the future there will also be novel and triplet therapies upcoming, which are very, very interesting. So it's really a great meeting. There are international speakers, but also a lot of local participants. The discussions are really highly interesting. The topics are really innovative, and there are also some rare topics, like we heard now from Professor Ramsey, for example, and I appreciate to learning a lot of these rare things also in these meetings.
So today I explain about the possibility to keep the bladder after neoadjuvant immuno or chemotherapies, or not to perform radical cystectomy in patients with muscle-invasive bladder cancer. Yes, it's a real hot topic now because we are awaiting some data for important trial, like the RETAIN trial, showing that probably it's possible for some patients to not perform radical cystectomy. What we are still missing is to understand which type of patient. So we are missing biomarker, we are missing to know the role, potential role of MRI, but also to understand the perfect neoadjuvant treatment for these patients. But the future is bright also in this field. This meeting is special because of the person who are coming here. We are all friends, I would say, because I also did a fellowship here with Professor Shariat, and the quality of lecture, it's really amazing. It's really easy to make questions, to understand, and every time I'm coming here for this meeting, I'm going back home with something new, not just regarding what I learned, but also regarding connection and friendship, and so it's very important.
Yes, we have today a really exciting thematic session about prostate cancer, and my part is castration-resistant prostate cancer, which is a difficult field because now a lot is happening in metastatic hormone-sensitive prostate cancer. So which treatment to use in castration-resistant prostate cancer? And here probably we have two highlights. The one is lutetium PSMA, a really good treatment with a survival benefit and especially well tolerable. So a complete new class of treatment. And the second is that we go to the new strategies of combination. That means we combine PARP inhibitors, for example, with the new hormones, with new results, with an increase in the radiographic progression-free survival. So that means patients profited a lot. Also, with regard to quality of life. So there is something happening in castration-resistant prostate cancer, but we all have to be aware that all these new drugs which are tested in castration-resistant prostate cancer will be tested in the future in metastatic hormone-sensitive prostate cancer, so that finally in metastatic prostate cancer we will have the possibilities to treat like in other solid tumors like lung cancer.
Today at CUO 23 I spoke about the sequencing therapies for metastatic bladder cancer. This has been an evolving field over the last 2-3 years. A lot is coming out, and we just summarize the next generation to look forward to would be the antibody drug conjugates plus immunotherapy. It is a potentially treatment line that might become important in the next near future. So it's my second time in Vienna. I have to say I love the city. The weather is not perfect, but we could not expect as much. I really like the meeting. It's very interactive and it involves a good discussion. So I look forward to next year.
My theme is management of clinically positive node prostate cancer patients. It's a very interesting theme because it's not so much of science done in this case of CN1 patients, and I will talk about diagnostic of CN1 in the modern era, so that's mean with a non-conventional imaging and of therapy options in these patients, which include ADT, so systemic treatment, and combination with local treatment. This is a combination of international experts on uro-oncological issue. It's a very nice place where this is done, and I think it's really interesting to see again new information as will be presented, really new data, and so I think it's very good for all people who came to hear us.
Today I was giving a talk regarding how can we make non-muscle invasive bladder cancer cheaper and better tolerated to our patients. And so I discussed with the audience the interest, first of all, to follow the EAU guidelines, because that's the cheapest way to improve the benefits in terms of recurrence-free survival and progression. Just apply the guidelines we want, and then to try to improve the tolerance and the price using different treatments. For example, gemcitabine docetaxel intravesical. We have few data that are coming up and are showing really interesting results, and it's very cheap to use. We also have a lot of interest in terms of reducing cystoscopy. That could be done with the new urinary biomarkers if the price is cheaper in the next years. And finally, I was giving a talk also on active surveillance and fulguration. Indeed, active surveillance is a new, really good trend in terms of bladder cancer patient management. Because it has basically a very low cost and it is very well tolerated because the patient has no invasive treatments. This meeting is for me very special. First of all, because I love Vienna, and the urology department of Vienna is an amazing place where I've been lucky to work during 2 years and a half. And this is a tremendous congress because all the people here are key opinion leaders, and the topics that we are discussing are not only the actual concern of all our urologists, it's also a lot of interaction we have during this congress that makes it definitely a must-have in your calendar.
The topic for me here is to give a bit an overview about challenges and successes in precision medicine during the last years, and also kind of personal judgment what I think that will bring us big step further, or what even might fail, or what might be important factors from the perspective of our models, different models, preclinical. So as a complement to all the great clinical data we see here throughout the day. I think it's a very great meeting by bringing together different disciplines and different networks. And I think this could really grow. It's international. It might get even bigger. So I think this is a very good way also in this friendly atmosphere, in this great building here. I think that is very unique with all these wax models around. And so it's really like a long tradition in the background of a very modern medicine, and I think that is what makes it very special.
My topic, I explored the new landscape of treatment for next-generation therapies in non-muscle invasive bladder cancer. We are living exceptional moments with a lot of new therapies coming into this setting, from BCG-responsive setting to BCG-naive settings, and in the future maybe also to the intermediate-risk disease. So new treatments coming, but new problems for the future for select patients for these new treatments. It's always a pleasure to be in Vienna here. I mean, I lived in Vienna for 2 years and I worked in the department of Professor Shariat. It's like to be at home in my beloved Vienna, and it's always fantastic to be here.